pathophysiology, common traps, and helpful tips and tricks to get the right answer. So we're going to be basically talking about a few differential diagnoses for commonly presenting cases, such as the one that's going to be presenting. And if you really like this type of teaching, please don't forget to like, comment, and subscribe for future videos. And also follow my Twitter and Instagram at match_doc. Thank you for listening, and I really hope this is informational for you. See you later. All right, everybody, how are you doing? It's the Match Doc, back at it again. So today we have a really cool vignette that I've prepared for you guys. So this is a 2-month-old African-American boy that comes in with crying spells. He has pain with diaper changing, hip is flexed, externally rotated, right? Hip is flexed, externally rotated, and abducted. He has a temperature, leukocytosis, right? Past medical history of breech and blah, 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 and then upper respiratory tract infection. All right, so this is how I do things, and I'll be making more videos in the future, but first thing I want you to do is have a differential diagnosis, all right? So differential. So what could possibly be the causes here? All right, so African-American child that has pain. I want anytime USMLEs, you want to be thinking about sickle cell disease, NBME, sickle cell disease, all right? Sickle cell disease. So another thing is hip pain, temperature, leukocytosis. You want to think about septic arthritis. All right, septic arthritis. And another thing you want to think about here that's very similar to septic arthritis is kind of like the cousin, but everyone gets confused, is transient synovitis. All right, and then another thing I want you guys to think about here, because of the history, right? Because of the history, is about the C-section and breech is developmental dysplasia of the hip. All right, so here, this is what we're gonna do. First, I want you to think about what the diagnosis might be, because I already know. But bottom line is, you want to have evidence that supports each of these differential diagnoses. There might be more, but these are the ones that you really want to think about for the exam. We're talking about the exam here. Okay, sickle cell disease, I'll give 1 point. Why do I give 1 point? Because the child is only African American, right? The child is African American, and they don't really give you any other clues to any other clues as to what the child might have. So African American, so that's 1 point. For septic arthritis, let's see. So hip is flexed, externally rotated, and abducted. So that's 1 point, right? Child has temperature, and child also has leukocytosis. So let's give septic arthritis 3 points. All right. And now let's go to transient synovitis. For all those who don't know what transient synovitis is, it's basically a transient infection of the synovium. Transient infection of the synovium. This happens because of post-upper respiratory tract infection. All right, so after you get a respiratory tract infection, there could be some molecular mimicry, and that can affect the joints. This is most commonly bilateral, right? And if it's not, it can affect the other joint. If it's unilateral, it can turn into bilateral, all right? So let's look at the things here, and this is not toxic. This is very mild. Okay, so child has a temperature, right? Leukocytosis, that's toxic already. This is a toxic presentation. Child's in pain. Hip is externally rotated, abducted, crying spells, right? High temperature, leukocytosis is pretty toxic. So for this, the only thing here is respiratory tract infection and then maybe physical exam. So I'll give this 2 points. All right, so the last one we have here is, let's use yellow. The last one we have here is developmental dysplasia of the hip. All right, so here this usually happens in mothers that get C-section and then the child that is breech. So breech child, right? And then hip problems. Let's give this 2. Okay, I don't know if you guys can see that. So developmental dysplasia of the hip gets 2. So who wins here? Well, according to the most evidence, septic arthritis wins. All right, so this answer is septic arthritis. So this is how like I usually teach and break down the vignettes in ways that will help students really get the answer right, because in reality is that we know we're taught a lot in med school about knowledge, but in order to apply the knowledge for the NBME, CBSEs, USMLE, step 1, step 2, step 3, you have to learn how to break down the vignette. They could give you literally a 7 sentence vignette, but this is all you need. In fact, this is not even all you need. You only needed to know that these 3 points: temperature, leukocytosis, and then the physical exam. So let's talk a little bit about septic arthritis, all right? And what happens in septic arthritis. So in septic arthritis, infection of the joint, right? The joint's infected. So it's infection of the joint, and this is what you need to know. There's 2 categories in children, all right? Under 3 months and over 3 months. Okay, under 3 months and over 3 months. So in under 3 months child, you mostly have gram negatives and gram positives. All right, and over 3 months is only gram positives. All right, so this is where microbiology comes in. All right, so gram negatives. Let's see, what's the most common cause of let's see, what's the top 3 most common cause of meningitis in a newborn? Well, you're thinking about, okay, so we have GBS, E. coli, and Listeria, right? So these are the 3. So the first one is gram positive, then gram negative, and then gram positive. Okay. So you're thinking about these types of things, and this is why, like, this is a mnemonic that you can use to kind of tell that septic arthritis in an under 3-month-old child, relatively newborn. Well, that's not newborn. Newborn is like under a month. That's called that newborn, a neonate. But anyways, under 3-month-old child, you can have gram positive and gram negatives. All right. So now let's talk about like gram positive. What are some gram positive that you can have? What I want you to think about is your staph. All right, staph. Always think about staph. In fact, staph is one of the most common causes of infections anywhere in the body. Staph aureus, right? Aureus. Okay, so now let's talk about treatment. So how do you treat this? Under 3 months, right? Under 3 months, how would you treat this? Always IV, never oral. This is a systemic infection, septic, right? Septic. Sepsis, so septic arthritis is you have a source of infection plus it's bacteremia in the bloodstream. You want to kill it off with IV. It goes directly into the bloodstream, IV. So you want to give vanc. Why? Why vancomycin? Because Staph aureus, right? Vancomycin is given for Staph aureus and it's mostly given for gram positives. How do I remember this? The V, flip it upside down to a A, positive, gram positive. Vancomycin is given for gram positives. All right, only gram positives, in fact. You never give vanc for gram negatives. The next thing we want to give, since it's also gram negative here, right, you want to give IV gentamicin, which is an aminoglycoside, yeah, aminoglycoside. You want to give this, remember it can cause nephrotoxicity and it can also cause ototoxicity. And vancomycin side effect is like red man syndrome, and it can also cause acute tubular necrosis of the renal tubules. But that's just a little bit of farm integration. And then gentamicin, and you also want to give something called ceftaxomine. All right, never give ceftriaxone in a young child. Never give ceftriaxone in a young child. Why? Because ceftriaxone is hepatically cleared, and in a young child, right, it's a general rule of thumb. Any child that is relatively newly born, let's say under a year, or let's say under like 6 months, right, their liver's capacity to function properly is kind of slowed down. Which is why you have physiological jaundice of the newborn, because the hepatocytes are kind of still growing and maturing. So ceftriaxone gets hepatically cleared, and if you have immature hepatocytes, that can cause cholestasis and increase liver function tests, right? can cause a little bit of hepatitis in the child. We don't want that. So this is the cocktail in a 3 or under 3 month old. Over 3 month old, you want to give, again, same vancomycin. Why? Because staph, right? And then other things you can give along with the vancomycin is Clinda. Why do you give Clinda? Well, Clinda is actually given for staph as well. All right, and you can give cefazolin. Right, it's like a little gram-positive cephalosporin. So this is what you can give, or. All right. So that's that's everything you need to know about septic arthritis. Another thing here that I really want to point out, basically how it presents. So it will present just like this. Hip is going to come with a child. It's going to have fever, temperature, leukocytosis. Can even have tachycardia. But the key thing here is there's passive and active. That passive and active range of motion of the joint, of the hip joint, causes pain. All right, this is both passive and active. What does that mean? Active means when the child moves the hip, it's going to cause pain. Passive means when the healthcare physician or healthcare provider, right, whoever's checking the child, checks the child and they move the hip, and then it causes pain. Or the mother, when the mother changes the diaper, it causes pain. That's another way of saying passive range of motion. Okay, so these are little clues in the vignette that can give you these important points. So that's septic arthritis in a nutshell, and everything you might need to know for the USMLEs. Let's talk about the other one, transient synovitis. So transient synovitis kind of presents similarly, except it's not toxic. Not toxic. Transient synovitis is not toxic, will not have a leukocytosis, will not have that much of a temperature. It will have a low-grade temperature, low-grade if it does. And it's usually bilateral, and if it's not bilateral, it will turn bilateral. So the first step in diagnosis of transient synovitis is get an ultrasound of the hip. And if it's positive, you get an ultrasound of the other hip, All right, you have to do this, other hip. Remember, you never get imaging in a child under like 6 months. Like, what I mean by imaging is like get an x-ray or get like a CT scan, unless you really need to, because it can cause radiation exposure. In children, you always want to do non-invasive radiations or non-ionizing radiations, such as ultrasound or MRI. Sorry, these are more preferred diagnostic tests. All right, so that's that. So it kind of presents similarly, except not toxic. And the key here is that you want to know that is the upper respiratory tract infection. All right, so they'll be sick. They'll have like cough, coryza, rhinitis. They'll be kind of, have the sniffles, and then a week later, 2 weeks later, they start having hip pain. So upper respiratory tract, hip pain, joint pain, right? Any joint pain. It's transient synovitis. Remember, something that's more pathological, like septic arthritis would be more unilateral, right? Will be more unilateral. It will be more septic presentation or toxic, like it's more of a systemic infection. Versus transient synovitis will be more mild. It will be bilateral, and it will be as toxic. And then that's transient synovitis. And what do? You just basically, for these children, you just want to give them supportive care, just support them. Give them Tylenol if they need. Remember, don't give aspirin. Do not give aspirin in a child. Okay, this can cause something called Raynaud syndrome. All right, do not do this. Do not give child aspirin. You can give children Tylenol for the fever if they have one. The supportive care, and it usually goes away. But on labs, they like to confuse students. ESR is elevated, which is ESR never tells you anything. It just says that there's a lot of inflammatory response. Don't get me wrong, ESR is important, but in this case, it will just any inflammation in the body, ESR will be elevated. Okay, so it's not much. So bottom line is the labs will not show as much as they would for septic arthritis, right? And if they do give you a joint tap, if they do a joint aspiration, all right, anytime you have a fluid accumulation anywhere in the body, doesn't matter if it's the lungs, the the peritoneum, right? The pleural, peritoneum, pericardium, right? It doesn't matter. You do an aspiration. You want to see what's there, what's causing that fluid, what is the fluid. And obviously septic arthritis would be like 50,000 or more WBCs. So that's the key, 50,000 or more. Transient Synovitis will be like really low, like under 2,000. Okay, it'll be pretty low. So there's that for transient synovitis that I just wanted to touch base on. And for developmental hip dysplasia, since I mentioned it, you want to, like, with the hip being involved and having a past medical history of breach, you might think this, but you want to think about certain maneuvers that are high here: Ortolani, Barlow, Galazzani, right? Test. Asymmetrical inguinal folds. So these are all for developmental hip dysplasia. This like causes clunks and clicks, right? Barlow is you posteriorly push the femur and then you AB duct it, backing out. Barlow, backing out. Ortolani, you anteriorly pull the femur and then you adduct it. Okay, so you anteriorly pull it, adduct it. Barlow, you posteriorly push and abduct it. And then Gazzellani test just shows that if you put the child on its back and then you look at the knee height, right, one will be less than the other. One will be lower. So if this is the knee and this is another knee, one knee will be smaller than the other. And then this shows that there's asymmetrical knee height, right? So that's a positive test. Asymmetrical inguinal folds. Basically, if you look at the folds of the child, the inguinal, basically if you look at the thighs and you see folds, right, on the thighs, there's two folds on each side. But on one side there's three folds or full folds on one side of the leg. That means that there's asymmetrical inguinal folds, and this is an indicator that the femur, right, is displaced and that there's more crevices on one side than the other. Okay, so what do you do here for developmental hip dysplasia? Well, here is pretty cool because the diagnosis you make by ultrasound, and this is the preferred diagnostic step and the best test to do under 4 months. All right, you do an ultrasound under 4 months of age. After 4 months, you want to do something called a X-ray. Okay, and this will show some developmental changes in the hip. The hip will not look normal. It will not be curved. It will be some dysplastic changes. It will be some fragmentation of the hip. It will not be the acetabulum socket. Okay, so I mean, I'll make another video of like things that affect the hip in a child, but I just want to touch base here. And the treatment here, right, the treatment for developmental hip dysplasia depends on the age. It's under 6 months. The child's under 6 months, you do something called a pelvic harness. It's a harness. You want to put a harness, holds the hips in place. 6 months to 18 months, you want to do something called a spica casting. All right, or you can also do a closed reduction, 6 to 18 months. All right, and then if over 18 months or over 24 months, so meaning closer to 2 years, you do open reduction, do surgery. All right, open reduction, you have to open it and then reduce it, it's surgery. And then here, sometimes they like to ask this, after a certain age, after 8 years, it's unfixable. It's permanent. All right, it's permanent after 8 years of life if you don't fix it before then. So that's a little bit about that. And then obviously let's talk a little bit about sickle cell disease because I mentioned it. 2 to 6 months and then onwards, right? What's the hemoglobin? Hemoglobin F. This has 2 alpha and 2 gamma. From 6 months onward, you have something called hemoglobin A1, which is 2 alpha and 2 beta. Where is the problem in sickle cell disease? Right? There's a valine replaces glutamic acid, right? On what beta chain? Sorry, I just gave it away. Valine replaces glutamic acid on the beta chain of hemoglobin, right? The beta chain of hemoglobin. Well, do you have a beta chain at under 6 months of age? No, you have 2 alpha, 2 gamma. You'll always have alpha chains, but you have a gamma chain here, not a beta chain. So you cannot have, basically you will not know if the child has sickle cell disease or not, or they will not present with sickle cell disease or vaso-occlusive crises, right? Vaso-occlusive crises before 6 months of age. So it's not sickle cell disease at all. So thanks for listening, and I wish you the best in the future, and I hope this really helped, and I'll have more videos coming up in the near future. Thank you.